right, we are back with another episode of Gatekeepers with your host, Dr. Jeff Dikis. Tonight, I'm joined by two very special guests, my friends, Kwasi Kwaadu and Jordan Sisto. Thank you, gentlemen, for joining us.
Thank you for having us,
Absolutely.
Jeff. Jordan, I just want to quickly point out how Jeff specifically noted that I was his friend, but then just kind of noted that your name after the fact. So I just want to just set the stage before we continue.
My friend Kwasi and Jordan. There's a little pause there. You were smart to catch that.
Oh,
All right, tonight we're going to be
I
talking
love
about
it.
talus fractures. These can be rather complicated, and this all goes back to an article that you did, Kwasi, quite a while ago, but it's still relevant. The anatomy of the talus hasn't changed. Some treatment techniques, the fundamental foundations of talus fractures, has not changed significantly over the years. We might get some new, types of screws, the headless screws, some compression screws, some different plates, some anatomic plates that fit in there maybe a little bit better. But the foundational principles of fixing these has not changed. So we're going to go through that article and talk through those real quick. Let's start with Jordan, and then we'll get to my friend Kwasi. Jordan, tell everyone who you are and where you practice.
Yes, I am Jordan Sisto. To those of you who do not know me, I practice out in Phoenix, Arizona. I'm actually part of Banner Health System now. So the majority, I probably say 90% of what I do is inpatient trauma type stuff. So um, you definitely get some good exposure to talar fractures at this point. So
Definitely. Kwasi, where are you at these days?
So I'm in Northwell Health. I'm in Northern Westchester, covering two hospitals, Northern Westchester Hospital and Phelps off of the Hudson. I kind of came up to assume some of the stuff that I'd kind of been doing already in Philadelphia to provide, reconstructive surgery in an area that generally not that it's lacking, but certainly is not as robust as say the main island in Long Island. And so the intent was to kind of really capture people from having to go all the way downtown. So that's kind of where I am, and that's what I'm doing now.
Absolutely. So we're going to talk talus fractures. Let's go ahead and jump into it. So this is the article that we're referring here. Clinics and PodMed Surge 2018 as part of the I was going to say the episode, but that's not right. I've got podcasts on the brain. The specific journal that month was Justin Fleming, who is your fellowship director, correct?
Correct.
Yeah. So talk us through this a little bit. Just give us a little brief history of, this article, writing this article, uh, you know, getting a peek behind the curtain for all the talus fractures that he takes care of there. And why did he tap you on the shoulder to help him with this article?
Yeah, I mean, I think just we're kind of similarly minded as it pertains to some of these things, and in as much as he trained me, and so I have the mind that he's pretty much kind of put into my body. We had an opportunity to kind of tackle a lot of these complex cases throughout training, and we kind of had a pretty unique situation, and so the idea was to kind of really provide that perspective. There's a lot of volume that we're doing, and so we try to review, again, as you alluded to, some of the anatomic components that can influence management and also, incisional approaches and those different type of things, and to kind of help provide, some information to some of the things that we're doing a little bit more regularly, and to just kind of review, our basic foundational principles in terms of managing something like this. So he approached me about it, and we talked about it, and I thought it was a good idea. We had a lot of images throughout the course of our training that I thought would be very helpful to share. So that was kind of really the impetus for putting something like that together.
Yeah, I find these clinics at PodMed to be very, very helpful. It's kind of a textbook that consistently is getting updated. So I really enjoy these. Jordan, do you look at these? Do you try to refer to these in any of your training? Obviously you have to pay for them, so depends on if you want to pay for them. But definitely in residency, we had a whole shelf, like bookshelves, full of all the versions that were out there, and you could go to it and pull it off the shelf and refer to it pretty easily.
yeah, 100%. I think the two things that really kind of lay the framework, and really understanding the principles and the fundamentals of trauma surgery is, I mean, this article was very well written. It was very well encompassing, kind of laid down the groundwork for a surgeon to understand, how to approach it, types of fixation, do we do it acutely? What are the complications, malunion? There's just so much things this is encompassing. And I would say the other kind of textbook that I refer to a lot is just the AO textbook as well. So these two I actually look back almost regularly, weekly, before cases.
Yeah, so we won't turn this into a lecture because I think it's far more interesting for us to kind of talk about our experience with treating talus fractures, but just to establish the foundation because I get a lot of younger listeners as well. Avulsion type fractures, neck fractures, and body fractures. There's a variety of different things that can happen to the talus. It's kind of like certain ankle fractures. When you see enough ankle fractures, you realize that no two are exactly the same. The way the bone breaks has a lot of variability to it. We're not going to go through the Hawkins classification. I put that in there for completeness sake. But yeah, Kwasi, what are your thoughts? This is an X-ray. All of these images I pulled from the article, aside from one of my cases I threw in here, and we'll talk about that in a little bit. But when we see this X-ray on the right, what are the first things that you're thinking? Obviously, anyone who tackles trauma knows that we rely a lot on CT scans. But when you look at that X-ray, what are the first things you're thinking about in terms of foundational principles of, what's the first thing you're going to do? They call you from the ER. What's the first thought that goes through your head?
Yeah, I mean, I think ultimately you're trying to get some level of improvement of the anatomic alignment. You're not looking for perfection by any stretch of the imagination, but you're looking to be able to kind of get a better idea of the segments, so you kind of ultimately can plan your definitive approach. And so the first thing I look at this, and the first thing I think of is X fix, right? Temporary fixation, damage control orthopedics is kind of the reference, right? We address edema, we address swelling, we realign the skeleton as best as we can, and then we image it, look at the anatomy a little bit more carefully. And again, I think people have their preferences at kind of the timeline of when to image. I think traditionally, when it certainly ankles, pylon fractures, some of these, once you get things a little bit better aligned, the imaging, the information from the CT makes a little bit more sense, so you can subsequently use that information to kind of plan your definitive approach. But, things happen. And, sometimes you might get in and the ED staff has already ordered a CT scan. And there's some injuries that may be a little bit milder in terms of their alignment that you may want to preemptively get the CT because anatomically the alignment is already acceptable to plan for that imaging. And so the first thing I think of is damage control X fix. That's the first thing I think of. Edema, elevation, that type of stuff.
Yeah, Jordan, what do you think? If we CT this, it's just going to be a jumbled garbage mess of
Mhm.
fractures and not even going to be able to see what's going on. Do you get a CT before your X fix or after? What are your thoughts on when to get CT scan?
Personally, like Quasi said too, I like it in a post-reduction CT scan, but like we alluded to earlier too, sometimes you don't, a lot of that stuff's out of your control, especially, I mean, where I practice, many EDs practice. Patient comes in, they get an X-ray, oh gosh, doesn't look normal, get a CT scan, and then it's like, okay, I don't know what I'm looking at, provides zero insight, does not help at all. So you just kind of have to ignore it and just move forward with the X fix and then do post reduction CT scan. So, but this is pretty common.
It happened to me just last night. I got called by the ED for impacted pilon fracture motorcycle accident, and they got a CT scan. I was looking at it, and it was impossible to tell what the heck was going on because the talus was driven up into the tibia, and the tibia was split into two different parts, and the foot was twisted the wrong direction. As I'm scrolling through, I'm like, I can't even figure out what's going on here. This isn't overly helpful because I can't even see the fracture pattern because of the displacement. So it does happen quite often. So, like you said, X fix is a foundational principle here, like we talked about, of managing these. And so, one of the things is soft tissue management, but one of the other things I think is important is maintaining height. If we go back to that x ray, obviously there's compression here. I don't know how this happened, but usually fall from height is involved with something like this, or maybe a motor vehicle accident slamming on the brake pedal where there's impaction. But what are your thoughts about maintaining height, Quasi, in terms of why we put the X fix on, not just for soft tissue management, but trying to maintain that length and that height so that when we do go in and fix it, it's not compressed and so tight in there.
Yeah, it makes your life a little bit easier. I mean, less so with the talus, but certainly the calcaneus. If you leave something like that malaligned, it starts to consolidate pretty quickly. And, then the small pieces get a little bit difficult to kind of really identify, particularly if you have a fracture that's a little more comminuted. And so, yeah, the maintenance of the height is just, really critical to your subs. It sets you up for later. And I think, there's some instances when we talk about AVN with the Talus. I'm maybe get into that a little bit, but there's some benefit in terms of kind of getting things back out to length, so you unkink some of those little small vessels. Certainly we're not looking at them macroscopically because they're so small, but we know that the blood supply of the Talus is rich, but it's tenuous, right? And so there are a lot of little vessels that maybe if we improve the anatomic alignment, even temporarily, we can kind of allow the perfusion to kind of head down the where it's supposed to go. So just collectively, those are some of the things that are beneficial for doing, but in order to kind of get that accomplished.
Definitely. Jordan, if we have a non-displaced talus fracture, what are your thoughts on cast immobilization versus screw fixation for either a minimally or non-displaced, specifically a talar neck fracture? Are you operating on all of those just because we know the blood supply is tenuous, or are you treating some of these non-operatively? What types of fracture would you look at and say, "Oh, I'll cast that," versus "No, I'm going to fix that"?
Yeah, I think, I've evolved for sure, especially since the advent of like, nanoscope, and just MIS generally speaking. I would say if you asked me 4 years ago when non-displaced Hawkins won, I probably would have done cast immobilization. It's always easy for us to say, yeah, 6 to 8 weeks, they'll heal predictably, but 6 to 8 weeks now weight bearing, having these patients follow up with you oftentimes for weekly cast changes. I mean, it's the cast atrophy, deconditioning. I mean, those are like real things that really never thought about when I was like residency or fellowship. And then you're in clinical practice, you're like, wow, this really does affect a patient's well-being and quality of life. And so I would say now, with subtalar arthroscopy, you can go prone and, those P to A screws sometimes can be very challenging, but with the advent of arthroscopy, you got direct visualization. It's minimally invasive, less soft tissue insult than already traumatized, soft tissue envelope. So I have been more aggressive, absolutely, for sure, in these ones because also when you think about it, the ankle joint passively, I think there's about 1,200 newtons that goes through that ankle joint just passively, right? That's a lot of load that can go through that joint. And, you know, in a patient, it's in a cast. There still is going to be some micromotion, especially when swelling goes down. I think the chance of malreduction and malalignment and then progressive post-traumatic arthritis is a real issue in cast mobilization. Hence why I think being aggressive, but doing so in a way that's minimally invasive can be very advantageous for patients.
Yeah, Quasi, what do you think? Obviously there's a lot of the lateral talar process, avulsion fractures, maybe a posterior talar process. Avulsion fracture, let's exclude those. But which fractures are you treating conservatively versus surgically when it comes to the talus?
Yeah, I mean, I think that, the Hawkins twos and above, by definition, they're displaced, so they need to be fixed. I think, the conversation here is really kind of about some of these more minimally displaced ones.
Right.
Um, they don't need to be fixed, right? Foundationally, they don't need to. But to Jordan's point, there is a the recovery is potentially a little bit longer, right? The way you have to manage it if you're not providing essentially internal fixation is external fixation with a cast. Um, there's a lot of tissue between the cast, the thing that's doing the immobilizing, and the actual thing that it's immobilizing. And so there's some movement potentially kind of between those spaces. Now, again, a minimally displaced fragment, you would suspect it wouldn't move as much, but the benefit of, I think, stable providing internal fixation, again, through a minimalist approach is early mobilization. I'm not putting you in a cast, as Jordan articulated. I can move your ankle. I can move your subtalar joint. Once your incisions are healed, I can start moving things around confidently. And, to Jordan's point, I mean, many times we get out in practice and we learn, the sequelae of some of these things that we otherwise were doing because we were taught to do. Right? I can't remember the last cast I put on an individual because the consequences. First of all, if they're applied incorrectly, they can have their own issues. But even when they're applied correctly, if the swelling ebbs, it's now loose, it's not doing a whole lot.
Yeah.
It's moving around, kicking around, creating abrasions, creating all these different things. But the disuse, the when you're moving your ankle around, there's also some benefits to kind of DVT, right? When you're moving your ankle around, the calf is pumping, there's, circulation of your vasculature. It's protective of some of these different things. And so, unless there's a hard reason, this person is really, really sick, they're on some anticoagulants that, is really catastrophic, possibly for interrupting those type of things, those really extenuous circumstances. Otherwise, I highly recommend fixing them because I think the recovery and the prognosis allows you to rehab much faster.
Yeah, and this is kind of a spit off of what you're saying with a cast applied incorrectly, but this is a splint. Particularly, I thought this was an interesting point with some radiographic evidence to support it. If you look at A there, which is here, we have a talus fracture, obviously, with posterior subluxation of the talus on the calcaneus, or you could say anterior subluxation of the calcaneus on the talus, depending on which way you want to describe that. Anyways, the talus is sitting on the posterior aspect of the calcaneus. And with reduction in rectus alignment, it's still sitting posteriorly. But when they put it into plantar flexion, it allowed reduction of the talus with that posterior facet into good alignment. Now, this is maybe not necessarily be as important for us, but it's definitely something that your ED needs to know about if they're the ones in there that are splinting these for you, because typically we teach or try to get to 90 degrees. Just put it in rectus alignment, put it there, stabilize everything, and let it be, especially when it comes to ankles and Achilles and things are maybe a little bit different. But I think this is an interesting point here that plantar flexory splinting is the correct way to splint these. I don't know. Have you guys ever thought about? I never thought about that before I saw this in the paper, so I wanted to draw attention to it. Obviously, you did, Quasi. This is your paper, but Jordan, did you ever think about that? Or
I have actually kind of in the beginning when I start seeing a lot of malreductions, status quo attempted close reductions in the ED, and then I'm like, let's just try to pull some traction. Um, you know, let's flex the knee, reduce the gastrocs. Let's see if we can actually anteriorly kind of bring that talus back underneath the plafond, and it seemed to work. It just helped me. It helped the case go easier because I was going regardless. I was going to bring the patient to OR, but I wanted to at least minimize the soft tissue insult
yeah,
to the overlying skin. And then also another thing that I really started doing too is I'm not a big fan of fiberglass. I think that's a whole nother discussion too. I like the plaster repairs. I think it just conforms better and it's more stable. That's something I've been doing probably since early residency. So anytime I see fiberglass, I it gets me a little upset.
yeah,
So
I do the same thing. I
it
do
just
I
goes,
think it's a little
yeah.
forgiving. The ED sometimes will do the fiberglass where you just pull it out and cut it, and then you dip it because it's
Mhm.
easy, it's quick, right? You don't have to worry about it. You don't have to sew. You don't have to wait for it to. It hardens a little quicker than the plaster. But then they leave that little part that goes right up behind the knee, and it jams them right in their popliteal fossa, and they freaking hate it, and it like causes some numbness down there. So plaster is a little bit more forgiving. Even after it hardens, you can kind of take it and kind of bend it if it goes up too high into the posterior aspect of the knee. So I agree. I'm plaster. Quasi, what are you? Fiberglass or plaster?
I don't specifically have a hard kind of, position either way. I've done them with fiberglass successfully, but I do want to comment on the fact that you pointed this out. That was such an important point for me to include in this paper because, to your point, I have never heard about it. I've
Mhm.
never read about it. Again, I'm not going to sit here and pretend that I've read every single thing, but I stay up to date with the medical literature. But I'd never heard about this, and
Mhm.
it wasn't until it happened to me. This was something that happened to me in the ED. The first reduction was my junior did it, and I'm a big chief and you suck, blah blah blah, and I come in and I do the top right.
Yeah.
Oh, you didn't reduce it properly, let me show you how to do it. And then I put it in neutral position, and and then Dr. Fleming came from the office and he did the middle one and he expressed that to me, in the back of the ankle. Again, the foot's going to want to sublux anteriorly, and so when you put in plantar flexion you kind of trap it, kind of like, so if you're holding like soap or something like that and it slips out of your hand, if you just kind of close down that posterior space, it makes it much less likely to. But I thought it was so important to include, even though it was a surgical paper, right? There's like all these different things about the topic. This was so important for me because it's kind of baseline management that I don't think it's anything that people think about because, again, typically we put people in neutral splints. And a lot of kind of biomechanically, some of my foundational thought processes inform other kind of ways that I splint people. Like for an Achilles, I'll put an anterior splint on, right? Because I want to buttress the ankle from extending. So there's these different ways that I will try to apply to kind of help maximize the performance of whether it's a plaster or fiberglass. But specifically between the two, I don't have a preference. But your points are well taken. The plaster does mold a lot easier.
Hmm. Yeah. So good takeaway here. Taylor fractures splint and plantar flexion here. So let's start talking about single incisional approach versus dual incision approach. Just real quick, uh, just one word, Jordan, one or two incisions.
Two.
Quasi, one or two.
Too.
I'm a two guy also. Okay, so we're going to be in agreement. This won't be very entertaining. Maybe I'll take the one incision approach and pretend that I'm a one incision guy, but I don't think that's the correct thing to do. So, Quasi, why two incisions? What is the benefit of two incisions in a world of minimally invasive surgery and do no harm? Why make an accessory incision?
Yeah, I mean, I think foundationally, it's hard to look at. The hindfoot's so complex, all these different kind of articulations and joints. It's hard to visualize. There's a lot of superimposition and stuff, and even when you're looking at it from one location, you may not appreciate a subtle malreduction on the contralateral side. And when the talus fractures, particularly kind of at the level of the neck, you know, a, not infrequently, there's a little bit more comminution along kind of the medial side of the neck, and so when hardware is delivered preferentially and exclusively through the medial corridor, sometimes what happens, even if you're not intentionally lagging the screws, your own strength, right? You're going to compress and you're going to kind of adduct the neck a little bit, and it kind of locks the hind foot. You're essentially, creating a hind foot varus, right? And so it can kind of create a lot of stiffness on the backdrop of an injury that already has stiffness as an expected complication. So it just adds to the collective kind of poor outcomes and functionality and everything. I do want to just kind of quickly comment when we're talking about the splint, we're talking about after initial close reduction. We're not talking about definitive ORIF posterior splints for those just after the reduction.
Right. Jordan, why two incisions for you?
Yeah, I would definitely like to echo what Kwasi said. I mean, he articulated it very well. A lot of these talar neck fractures do have that dorsal medial comminution. And if you just go through, let's say that your typical anterior medial approach between the tibialis posterior and tibialis anterior, um, if when there's comminution, it's really hard to get a cortical read. And so by doing that anterolateral incision, you usually have larger fragments to work with. Usually just one clean fracture line for the majority of cases. Obviously, these are all a little bit different, but for the most part, you have a much better read laterally. And so I usually will do my definitive fixation laterally. That ensures that the talus is anatomic. Then I will work my way immediately where like it is very easy to leg just by your own strength. And so those are ones where I'm only mostly I say 99% of the time I'm using positional screws in that area just because of the combination and the high incidence of dorsal malunions and midfoot supination you typically see as sequela.
Yeah, I agree. For me, it's all about optimal reduction. We know that there's issues with dysvascular nature, especially talar neck fractures. Everyone knows the Hawkins classification, but it's all about the reduction. And so I find through one incisional approach, it's visualization. But I also find that if you only have one incision, or even if you do have two incisions, you can see it happen. As soon as you go to reduce or compress one side, it distracts on the other. It almost toggles back and forth with the talar neck and the talar head inside of the navicular. Obviously, the navicular has the convexity and concavity to it. And so it wants to move very freely versus some other fractures that are a little more stable and contained. The talus on the navicular wants to move and rotate. So I find that if you don't look at both sides when you're doing your reduction, if you, let's say you just did a lateral approach first and you did your reduction and then you opened up medially, I bet you would not like your reduction medially, even though you loved your reduction laterally. So it's important to look at both sides of the talus, visualization wise, but most important to me is reduction and optimal reduction. So this is a lot of wires in there. So what is your thought process, Quasi, behind pinning everything into optimal position? Are you pinning everything and then using a select few to throw cannulated screws over? Are you just doing however many pins it takes to get everything into anatomic alignment? What's your thought process here by just pinning everything back first before your definitive fixation?
Yeah, the thought process is again things we've articulated already. I think there are instances where you may be fooled into thinking that you have something, anatomically reduced, and you kind of go to a different area of the site, and you kind of realize maybe it's a little bit less than you would like. And so the idea of just providing comprehensive temporary fixation is to kind of make sure that we have everything captured where we want it to be, and we can kind of start to kind of provide a stabilization. So that is my default. I think when I'm teaching young learners, residents about the talar fracture. However, with that said, of course, there are instances where as I'm progressing, I may find, hey, I got good bone here. Let me capture it. Right. I'm going to put a screw in, progressively go along. And so, again, I think foundationally, it's good to have everything temporarily fixed. But as you progress in your career, and you definitely are able to cut some corners at times without question.
What are your thoughts on pinning everything fully and then doing your definitive fixation versus pinning and checking and maybe throwing a screw here, one or two along the way? How do you tackle these?
I honestly do the exact same thing. Sometimes I will leave the external fixer on too, and use that as a distraction tool. It kind of aids with reduction a lot too. But I've noticed, earlier on in my career, I just put in a pin, put in a screw, remove the wire, then I would see some shift, and then I had to remove the screw, and then I learned really quickly after one or two cases where it's best to kind of treat these like calcaneal fractures where you have multiple wires, sometimes more than you need, but it ensures that you don't get that malrotation after you put in your screws, especially immediately when you have the comminution. But yeah, I think these are not easy. This actually looks beautiful. So really good job on that. The X-rays always look beautiful, but getting here, it's so darn challenging because I mean, this is probably an hour into the case where you got things right now. You have to do the definitive fixation. So
What about
Full disclosure, this is Dr. Fleming's work. I just want to be very clear. I don't want to take credit for anything.
we would have never known? Um, so what are your thoughts, Quasi, when you have, a lot of these fractures are high impact, they're high velocity type injuries in order to break the talus. What are your thoughts on bone loss? Because it's much easier to get cortical reads when you have all the bone or the articular surface is in place and not crushed. What are your thoughts on bone loss? Are you adding bone graft? Are you adding bone putty, cancellous chips? How are you filling bony defects with the comminution and compression of bone loss during reduction?
Yeah, you have to backfill if you have deficits, because again, foundationally, the talus is so critically important to its function, so it has to be foundationally restored as best as you can possibly restore it. I like to I have a kind of a similar concoction for whether it's a fusion or much of this. I will do BMA from the proximal tibia. I'll mix it with some cancellous cubes, and I'll mix it with the Vanco powder. The Vanco powder is not for antibiosis by any stretch of imagination. I mean, this is a good carrier. It turns into this kind of like Play-Doh with like crunchy putty in it. That's just really great to handle. That's what I utilize for virtually everything.
I use that a lot too, especially with loss of height, calcaneal fracture, talus fracture, anything where I'm trying to maintain some structural integrity to the bone. What do you use, Jordan?
I definitely started to get very fancy with these products. I use a lot of actually Ceramide G. Just I it's the calcium sulfate, but I like the idea because it absorbs during the course of the bone healing process and actually becomes bone. And instead of bone loss, it does harden after about 8 minutes or so, and you can drill through it.
You
Um,
have to be you have to
with
be a little
putty and
careful.
things like that
Um,
historically,
there are some products you can drill through, and there are some products you cannot drill through. Should probably take
yeah,
those off the shelf because I
yeah.
don't know why we would ever use that. Why would you put in a bone graft that you can't drill through? Or try to do something later if you needed to. But just be careful with that. Anyone listening, there are products that you cannot drill through later.
Don't know how many times you put in the putty and then you put in fixation and you just see all that putty just evacuate. Nothing's more depressing at the end of a case like that where you start seeing that. So I started kind of exploring different options, and I've just had really good success with those antibiotic cements that can kind of resorb into bone.
Yeah, definitely. So if you're aiming to fix this, Quasi, what are your thoughts? Are you always trying to get a plate on laterally and screws medially, or are you just going with whatever fixation you can get in there, depending on the structural integrity of the bone? What in a perfect case, what would you be aiming to do with your fixation?
In a perfect case, I have a type 1 and I can just do percutaneous screws.
There
That
you
would
go.
be ideal.
Yeah.
So I think that's my go-to. If I have a good osseous substrate and I'm not concerned that there is, significant comminution or impaction along where I can kind of get some good cortical digitation. Screws are, they're quick. All right, you put them in and you're done. Positional screws. Otherwise, if I'm concerned about length and rotation, the twos. So, truthfully, twos or anything two and above, you're almost. I'd be surprised if you don't have to plate them.
Yeah.
It's very rare that you're lucky enough. Again, high energy injury comminution is not uncommon, even if you're not necessarily appreciating it, because the comminution, what happens sometimes you have frequently is you have this impaction, right? You have this cantilever bending of the tail and neck, but then it kind of docks into the fracture pieces as well. And so when you kind of unpack it out, you can kind of appreciate some of the defects a little bit. And so uh, plating, lateral straight plate, maybe one or two kind of medial positional screws are probably generally the normal construct if you want to accept that terminology. That's generally kind of what I go to generally.
Yeah, so for any of the younger people listening, essentially what he's saying is screws work really well if you have two pieces of bone, one fracture, you're screwing piece A into piece B. As soon as you start to get some comminution, some bone loss, some impaction, a plate, which can throw screws into a variety of different pieces of bone altogether, is a much more stable construct than one screw that really doesn't have a good bite through any of those small pieces of bone. Jordan, what are your thought processes on what fixation you're trying to use? Are you in agreement with what he said?
Yeah, I try to use screws whenever possible. Because for me, and when you're talking about the talus in particular, you really want to minimize your subperiosteal capsular dissection, right? Because oftentimes in these fractures too, you have to understand the vascular anatomy, and oftentimes the deltoid's the only anatomic artery that's supplying the talus. And if you're making your medial incision, which it sounds like many of us are, limiting your exposure medially is one of the best things you can do. And often if you can do that in some Hawkins too, but when you start talking about comminution, you definitely have to be much more cognizant and really look out for the deep deltoid and just preserve it, because I think that's likely the big reason why some of these go on to AVN of the talus.
So this is one of my cases here. This is a high-speed motor vehicle accident, impacted talar neck fracture. You can see here radiographically on the left-hand side, and then CT scan here on the right. So, Quasi, what are your thoughts? I'm not pimping you, but just a kind of a straightforward talar neck fracture, but with some impaction and some comminution there. Are you taking this patient straight to surgery? Is this an X fix? Is this splint and follow up my clinic? We'll fix it whenever I can get to it, when I'm done golfing. What are your thoughts on that?
Yeah, outside again, this is isolated injury. This is one where I think you could splint them and, just kind of, focus on the edema control. And once that resolves, I think you can kind of take them. This isn't one where I don't think the alignment is so bad that it needs an X fix. I don't think an X fix is wrong, but I don't think this one is something that requires it.
Yeah, I agree. I did not X fix it. I just took it to the OR, and this is the uh, lateral side here. You can see the impaction of the talar neck. And so what we're looking at here is the talar head, the talar neck, and then the talar body back here. And then this is the fibula here. So we're doing a lateral approach. You can see that there's some bone loss there. So this is not a very good cortical read. So you open this up and you try to put fractures back together, and you want them to fit together like a puzzle piece. You want to get that, oh, yep, that's exactly where that goes. And so the difficulty in this one, this type of fracture with the impaction, is how much length do you need to regain? How much bone was lost? How do you handle that, Quasi? Do you, obviously, we clinically you can see here, but radiographically you can use that as well. We have intraoperative fluoroscopy, but how much length are you expecting to try to get? Because it's really a guess because you've lost your cortical read. So how much bone graft are you implanting in there, or are you just going to fix it as is and accept a little bit of shortening of the talar neck?
So I think with a lot of these traumas, we CT a lot of folks, but I think contralateral images are important and very helpful. In the absence of contralateral trauma, right? You have a
Sure.
uninjured contralateral limb. It can be very helpful because, to your point, when you have this impaction, you have these rotational deformities at the level of the tail and neck. It becomes very almost impossible to kind of really identify them effectively, and so you're kind of guessing now. There are radiographic parameters you can utilize, right? You can use MIRIs, Kite's angle, all of these different things to kind of help provide you some guidance. But those are essentially kind of your best bet at that point, right? Cortical interdigitation, if you don't have it, look at the contralateral images to see if you can kind of mimic what you have on the contralateral side, and then look at first met talar neck, talar bisection on the DP and the lateral to kind of help provide you some guidance.
What are your thoughts, Jordan? Do I need to put a Hinterman? Do I need to put some pins in there and distract it? Or can I just smash some bone graft in from the side and let it fill in the defect? How would you approach just a little bit of shortening of the talar neck?
Yeah, there's definitely a gray area in this one. There is just a little bit of comminution that it's not like a slam dunk percutaneous. This is open. This is a perfect case, and this is actually a case that like, one of my first ones in practice where I actually ended up getting a varus malunion on because I thought it was a slam dunk, perk some screws, and then I ended up getting a malunion. This is one that needs to be opened up. You got to be very cognizant that if you overcompress laterally, you're going to see on a canal view that you're going to have distraction immediately. And so, getting the contralateral films, if there's not a polytrauma or contralateral injuries, posting them in the operating room right next to the big C arm. That's something I've done now since my first case where I had a varus malunion. So now I am looking at that every single case,
Yeah,
and that can be very, very beneficial.
great advice there. So this is my fixation construct here. You can feel free to be hypercritical if you want, but there's a plate and it was not an anatomic plate. I think I took a small plate and I bent it, and when I first put it on, it looked good. But what had happened was that the plate was a little bit too long because in the OR the foot was in a little bit of plantar flexion. So if you go back, you can see here picture in plantar flexion. All right, screw. You get the idea. You know what plantar flexion looks like there. So there's a lot of talar body room right there. So I had the plate extending all the way up into here to get good bite into the talar body. And then I put it through range of motion, the plate dink right into the fibula. I was like, oh, well, yeah, that was dumb. So what are your thoughts on that? Just don't make that same mistake, obviously. So I had to take the plate and all the screws back out and cut off that hole and then put it back in there and it fit pretty well. But are you aware of that, or what position do you have the talus in when you're fixating this?
Yeah, I mean, I think so in the paper that you reference, I think we talk about some specific locations that because again, to your point, 60-70% of the talus is almost cartilaginous, right? And so we're not trying to put screws necessarily in those locations. And so there's very kind of limited areas. So along the medial side, below the comma shaped facet, you can sneak a little 3-hole plate underneath if you need to plate the medial side. Along the lateral side too, to your point, I don't necessarily extend the plate quite that far. The plate kind of lays along that curvature and doesn't extend necessarily into the lateral gutter. And so just kind of like how you have it demonstrated, the screws kind of fan out. And so along the lateral aspect of the talus, the screw is more A to P than medial to lateral, right? So the head and neck screws are more medial lateral. and then the screws that are a little bit anterior to the lateral facet are more A to P, and so I keep them short of the gutter. But as you referenced, you grab any 3-hole, 2-hole plate. Doesn't have to be tailor fracture specific. A lot of these smaller ones are more than adequate.
Yeah, this is just what I had available here to fixate this. Anatomic plates are fantastic, and when they fit perfectly, they fit perfectly. And when they don't, it's super annoying because then it's off just a little bit. And sometimes you're better off taking a straight plate and bending it and contouring it to what you need it to. But you can see in this view right here, this is where that plate had extended up proximally, and I had two screws into the tailored body, and I was pretty happy with two screws on either side of the fracture. But I unfortunately had to lose that one. Jordan, what are your thoughts on fixation and any thoughts here?
No, I think this looks good. I think, this is something I kind of go away from those pre-contour plates, to be honest with you. I have more troubles with those. I'm just more a fan of getting like mini frags, 2.0, 2.4s, pre-bending it myself and doing it that way. Because I think those pre-contour plates, and I say the same thing about those list frame plates and all the pre-contour plates. It kind of puts bones in certain positions that I necessarily don't want them in, especially when there's like bone loss. And um, so I kind of I've been playing around with that and just started doing mini frags and keeping it as simple as possible. And I've ran in this problem multiple times in the OR, mostly with those pre-contour plates.
Say if I was being hypercritical of myself, the fixation is all fairly dorsal. I don't have much compression or stabilization down here at the inferior aspect. Didn't seem to matter. This patient healed and did quite well. But it's difficult because clinically, when you're in there in the OR, your incision kind of guides where the plate can fit. And on radiographs, you look like, oh, it needs to be scooted down all the way, and then you're like, well, I can't do that intraoperatively. Like there's tendons and there's the real world gets in the way, and so sometimes your fixation of what you think it should look like radiographically does not match with your clinical orientation of what's available or what lines up and makes sense
For, for,
intraoperatively.
Fortunately, what's great about the utilization of non-locking screws and so forth is that the talus is an incredibly hard bone, and so you don't specifically need locking fixation, and so when you contour those plates, you can still kind of get a pretty robust kind of bite through a non-locking screw, even with 2.0s and 2.4s.
hmm So this is what the
Can
fixation
we go
looked
back
like
to that
intraoperatively.
previous image?
Which one? This one?
So this is one thing I see too, because usually those screws, it looks like you are extra articular too, right? You're not actually going through the talar cartilaginous head region
Correct.
medially.
Correct.
Yeah. 'Cause I
Yes.
usually, if you ever want to be
Superior
more
to
plantar
like
too, yeah, you kind of have to countersink like plantar medial to really be plantar. And so sometimes, so you do have to violate the talar cartilage.
mhm,
So this is actually nice that you didn't violate the talar head whatsoever.
right. So these are just my key points here. We've hit on all these before, but incisional approach there. So what are your guys looking at? So with this approach, I just did kind of that standard lateral approach and reflect off the EDB. And as soon as you reflect the EDB off of there, you have pretty good access to the talus. But do you guys have any techniques, quasi, for incisional placement or alignment or what to avoid or anything from that standpoint?
No, I mean that corridor again is relatively safe, right? Really, once you get past the superior peroneal nerves, there's nothing really of major consequence in that area. And so again, lateral mal, fourth met base, that incisional kind of corridor, you can access the lateral aspect of the tail is pretty generously.
What about you, Jordan? Are you using kind of like the extended talonavicular incision and shifting it up a little bit uh, proximally as you go, or what's your anatomic alignment of your incision?
Yeah, immediately I'll mark out the medial mal every single time, and I will start there and kind of work my way distal. I will try. I really don't do malleolar osteotomies, so I try to keep it as distal as possible, just to try to avoid the deep deltoid and preserve that. And laterally, mark out the anterior distal tibia, the triput, and kind of work my way to the fourth limb base. Identify the EDB and full thickness, elevate, and have a really good visualization.
Yeah, even though talus fractures themselves can be very difficult, the incisional approach I don't find to be over complicated just because once you get in there, you reflect the EDB, boom, you're staring right at it. So pitfalls, we kind of talked about this a little bit. And as the technology that we use advances and evolves a little bit with headless compression screws or um, anatomic plates, like we talked about, we want to make sure that we don't have any prominent screw heads. That's kind of a common sense thing. Countersinking. So Quasi, I assume that this X-ray is from a while ago, and now you would be using a headless
Yeah.
screw. But I don't want to put words in your mouth.
Yeah.
How have your fixation options changed over the years?
Yeah, again, this was also one of Dr. Fleming, so just full disclosure. But it was minimally displaced fracture, but we wanted to kind of essentially help the patient's kind of prognosis and recover a little bit quicker. And so the thought process was kind of provide this. So it was one of those cases where this was kind of what's available. But yeah, great point. Large screws like that can be problematic behind the ankle, and so you got to really sink them in. But if you utilize headless screws, go with that. The benefits too, I think sometimes you got to think about. I don't know. Sometimes I think we talk about biomechanics so much that we don't recognize that we don't also point out or emphasize the reality that patients are healing, and so biomechanics isn't the end all be all. But when you're utilizing these screws, obviously solid screws, this is a fully threaded, non-cannulated screw. Excuse me, is a partially threaded non-cannulated screw. It's a solid screw. So again, the bending moment you reference your fixation with the tail and neck fracture, how the hardware was a little bit more dorsal than plantar. Obviously, with the neck fracture, it's cantilever bending with the fracture starting inferiorly and propagating along the neck, and so having fixation closer to the bottom is protective of that. And so, oh, all points taken, right? But the utilization of, I think, fully threaded screws in this case, headless, are probably advantageous.
What are you asking for if you get a talus fracture? What size screw are you using? Headless? Are you using compression screws? Are you using positional screws? What are you trying to ask whoever the rep is, no matter the company? What kind and size of screws or plates are you looking for? You
Yeah.
said plates was the 24, 27.
Right. Yeah. So I utilize I will request, a comprehensive set with a bevy of, whether it's hand screws or mini fragment type screws. So anywhere from 1.5 to 2.0 to 2.7. I'm using old traditional Depew kind of numerical values here. So that's what I would request for the plating. And then for if this was a type 1 and I wanted to do just a single large screw kind of oriented this way, I would maybe do like maybe 2.5.0s, 5.5s, or a 7.0. Again, in those instances, I'm utilizing a cannulated. Again, in this image, it's not a cannulated screw, but I'm utilizing a cannulated screw because, again, it's a fracture that's not displaced significantly. I am trying to gain some compression across those sites. Again, as you articulated, it got two big pieces. If I can compress it, it's ideal. But if I have anything where it's a 2 or 3 and it's comminuted, I need kind of small implants.
I'm a big fan of headless screws because they don't have the prominence. But we know there's a high incidence of post traumatic arthritis in this type of fracture, avascular necrosis, which potentially means more surgery, which potentially means, knock on wood, no, but having to go find your hardware. Those headless screws can be more difficult to find. Jordan, what type of hardware are you using?
Yeah, I'm pretty basic when it comes to these. I do like headed screws because if I am doing these PDA screws, I now do them under nanoscope, and so I can actually directly visualize it. And I typically use solid, fully threaded if I do not like my provisional wire fixation. If I do like it's like an interoperative decision. If I do like my provisional fixation, I will use the partially threaded cannula, but just be very cognizant to knowing that those threads do, when you are going P to A, you have a much smaller area to get those threads across the fracture. And that's the one thing I'm always looking at. And so sometimes that was going to determine whether I use a fully threaded or partially threaded as well. So
Quasi, do you do any malleolar takedowns. It depends on access, obviously, but obviously that adds some complexity to the case. But how often do you find yourself doing malleolar osteotomies for adequate visualization of the fracture or reduction?
I've done one, and it was for a complex body. It was never for a neck.
Hmm.
For the next worst case scenario, I think you can potentially even loosen the ATF and subsequently go and reconstruct it, do an anterior drawer, so you can kind of really sublux it forward and access it, and even do. You don't have to get creative, because if you're acutely sectioning it, you can just primarily repair it, because the individual is going to be non-weight bearing for such a prolonged time period that that thing will scar down anyway. So you're less concerned about destabilizing the ankle. So it's incredibly rare that I'm cutting the tibia to access
Yeah.
this.
Jordan?
Yeah, definitely echo that. I've had one non-union. And then with the advent of the medial posterior medial approach for those posterior medial body fractures, that's pretty incredible. The visualization you have of the posterior medial talar body. So I haven't done one in probably 3 years.
Yeah, which is good. The less malleolar osteotomies is always better. This is kind of what you're talking about here, Quasi, with sectioning the ATFL, which I think is a very good approach. Seems like one step backwards to take two steps forward. You're doing more damage in order to hurt it, but isn't that really what surgery is? We're making more damage. We're hurting things in order to make them better. And so sectioning the ATFL, doing an anterior drawer, and getting better access to the talus is very reasonable. We're coming up on the end of the hour here. If anyone has any questions, go ahead and throw those into the chat. I know that talus fractures are not for everyone, and I think anyone who does talus fractures maybe wishes that they didn't do talus fractures because they are quite complex. But even with proper fixation, we know that there's risk for avascular necrosis. So, Quasi, what are your kind of, we don't have to take a deep dive into avascular necrosis and all the stuff that comes along with it, but do you have any kind of pearls for monitoring? Are you getting MRIs? Or are you just waiting to see how they do first? What are your thoughts on that?
Man, I think it's different for everyone. I think, number one, it's about education, because, when you have this acute injury at the onset, even with pylon fracture and all these different things, coming out of Temple, I would always educate our students and tell them, if an individual comes in and they have ankle arthritis, and, you know, ultimately only talk to them about possibly doing an injection, I think there's still some benefit to kind of educating them about what they may be facing down the line. Hey, listen, this may not work out. You may need to clean up, fusion replacement, etc. When you have a talus fracture, to your point, you reference even the idea of possibly going back and removing hardware. It's not uncommon that these patients require repeat surgery. So I think it's important to kind of just plant that seed. That said, individuals with AVN, again, it's about monitoring. Individuals who have radiographic evidence don't necessarily proceed to collapse, and so we watch them. But we're going to talk about, hey, you got this thing brewing that may require some, maybe some heroic interventions. And so, how I manage it is I educate the patient early, 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 before I do anything.
What are your thoughts on any exogenous supplementation? Do you do any vitamin D? I know that some people do some of the osteoporosis drugs or some of the things. I think the data is a little murky on that, but do you supplement anybody that you're worried about AVN or bone quality postoperatively?
This is for me, Jordan.
Whoever.
I
I
have.
don't do any of that.
I gotcha. I haven't. I haven't in the past. I mean, I think, now shout out one of our former residents when I was at Temple. Her name is Sarah Mateen. She's out in New Jersey practicing. She and I did a little bit of a dive on. I went through a process where I was just collecting vitamin D levels on all of my osseous reconstructions. We just wanted to see whether it mattered, because a lot of that had to do with, regionally. If you think about the Northeast quarter of the U.S., there's less sun exposure compared to, say, the West Coast, and so generally people in the Northeast quarter of the US have lower vitamin D levels. It doesn't necessarily translate to worse patient outcomes, a higher non-union rate, et cetera, et cetera. So we actually looked at our data. We actually found, again, take it for what it is. I don't think you can rely on it too much, but we actually found that we had higher union rates in patients who had lower vitamin D levels. It was merely observational. And there are a host of reasons, obviously, that possibly could explain what we encountered. But long story short, outside of reconstructions that have failed, or there's some hard reason as to kind of why things aren't working out. I'm not I'm not big into, I'm not big proponent into regular use of vitamin D in most of kind of my treatment management. A lot of patients.
See, I do use a lot of vitamin D because I do see a lot of vitamin D deficiency. And in my cases, the reason I'm checking for vitamin D is usually because I see a problem, a non union or
Mm,
slow bone healing or something like that. And I check it. I had a young girl one time. She was like 17. I did a lapidus and it was just looking awful. Her incision wasn't healing
mm.
and the bone looked terrible. And I was like, I don't know what's going on. You're young, you're healthy. I checked her vitamin D and it was 9. I was like, holy
Mhm.
moly. And we supplemented her, and it was like, boom, everything healed. The skin healed, the bone healed, and she did fantastic after that. So I do factor that in. Jordan, what are your thoughts on supplementation, uh, vitamin D or otherwise?
I've really only started to look at it over the last year because I've been more health conscious personally. So I've just dived in and went down rabbit holes of nutrition. So historically, I would just give everyone 5,000 international units of vitamin D, and just assume that that's going to help their healing process. But then knowing that vitamin D can't be absorbed without vitamin K3, so the vitamin D2 K3 supplements tend to be really good. To I haven't really seen any. I don't. I couldn't directly compare and see if that's actually helping and makes me feel better. Um, I think that'd be a really good study, to be honest with you. Seeing like a head-to-head cohort, but all purely level 36 evidence anecdotal in my territory.
Unrelated to Taylor AVN, I now check vitamin D levels on all fractures and fusions preoperatively. So just so I know, because it saves a lot of headache down the road when I see these people and they're not healing, if I can catch it earlier. Um, Quasi, I don't know what the people are doing out there. They're healing better with low vitamin D. We need
I,
to, I,
I'm not
I
here
had
to
this.
explain. I'm not here to explain what I found. This is what we found. It was
Okay.
interesting.
It is interesting.
I will tell you, if Jack Schubert heard you ordering all these vitamin D levels, he'd lose his mind.
Dude, I'm telling you, these people, they come back at like 9 and 13, and we're sitting on these simple, like Weber A ankle fractures that just aren't healing after 3, 4 months. And then I check it and then I supplement it. And it's like, boom, heals. Wild. Um, all right. I don't even know what this one's talking about. Hybrid fracture patterns. We don't have time to get into all that. We're at the end here. So plates, screws, wires, those are for body fractures. Again, we can talk about all that stuff. So let's go ahead and wrap it up there. I think we touched on a lot of different aspects of talar fractures, went through that case, talked about fixation options, including sizes. We talked about avascular necrosis, incisional approaches, dual incision approach. I don't see any questions in the Q&A or the chat, so I will wrap it up there. Anything you'd like to leave us with, Jordan?
Yeah, I would just, definitely say one thing. These are not easy fractures to undertake. Take your time, get a CT scan, post reduction if you can. Be patient, be comfortable being uncomfortable. Sometimes they heal, sometimes they don't, but these are fun, complex, and sometimes can be humbling, but someone has to do them.
Definitely. Quasi, any thoughts for the people as we leave?
Yeah, I mean, first of all, kudos to every single person on this chat. I mean, it's you could be doing anything, and you're bettering yourself. You're doing some education, you're learning. So we appreciate you joining us, and I hope you take a lot away from this, and perhaps maybe in the future you get in the position that you can contribute, so we can kind of keep passing this along. And Jordan, officially welcome to our friend group.
Yeah, let's go. Finally.
Thank you,
All right.
guys.
Thank you, everyone, for joining us on this episode of Gatekeepers with your host, Dr. Jeff Dikis. For Jordan Sisto and Kwasi Kwaadu, I'm going to throw over to Rich in honor of 4th of July. I wore my 4th of July Wolf t shirt. So happy birthday, America.
Beautiful.
Hey, congrats to Jordan, man. Just had a baby girl last night. I mean, come on. He didn't have, obviously, but
He's in a little
Congrats,
hot water.
congrats, Jordan, and everybody on your family side. It's a blessing. It's a blessing.
absolutely.
Thank
Absolutely.
you.
Have a good night, everybody.
Thank you, everyone.
Take care, guys.
Excellent night.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.